Okay, good morning. This is our start of our PPE precaution video. So, we have a respiratory virus, and as you'll find in the Canadian simulation game, they're talking about, specifically about COVID, but this could be any respiratory virus, so I wanted to make it applicable to all. So we have examples are a respiratory virus would be influenza, RSV, and then of course COVID. How is it transmitted? From what we know currently, like other respiratory viruses, it's transmitted via, starts with a D, droplet. So it's transmitted via droplet. So the virus attaches to drops of respiratory secretions. All right, let's talk about some examples of respiratory secretions. What are some examples? Well, we have someone coughs. So anything that you do that's going to expel your goop or mucus on someone else. So cough, sneeze, and then also talking, because when I talk, I'm spitting gunk everywhere, right? So talking will also expel droplets from our mouths. Okay, now the other way that it's transmitted is via little objects that can be contaminated. Inanimate objects, so not people, not animals, but a contaminated object. And in the epidemiological world, those contaminated objects are called fomites. Fomites. Okay, now we know that it is not transmitted through animal contact. Okay, so now let's talk about our patient history questions. What are we going to ask our patients as you are coming into contact with suspected COVID patients in your clinical facilities or in the little emergency center pop-up tent areas that you're going to be triaging people with suspected COVID? So let's talk about this. We want to ask them 6 very, very important questions. The first thing we want to ask them has to do with symptoms. The first 3 things have to do with symptoms. So our first one starts with an F. Very, very simple. The most common symptom that people have been reporting is a fever. Okay. The second most common, or one of the common, is a cough. Then we also have SOB, stands for shortness of breath, as we know it, not the other one, or otherwise known as dyspnea. Okay? Now we want to talk about travel history within the last, how many? Travel history within the last, sorry, I moved over, you couldn't see it on the camera. Travel history within the last so many weeks. So how long, why are we worried about travel history? Well, now we got to start thinking about incubation periods. The incubation period means that from the time that you were exposed to it, it enters your body, you know, through your respiratory tract. How long does it take you to become symptomatic or have the disease? So, travel history within the last 2 weeks is what we want. So we know that COVID, from what we know, now this could change, what we know right now, COVID has up to, so anywhere between a 4-day, sometimes 2-day, up to 14-day incubation period. So that's quite a long time. That's why when someone is exposed to COVID, they have to self-isolate for 14 days. Okay? Because if they haven't shown symptoms in that 14-day period, then they are now clear to enter back into out of isolation. Okay, so now let's talk about what else do we want to ask them. What is a question we want to ask them you want to know about their history, right? Because some diseases put them at higher risk for bad outcomes, poor outcomes, shall we say. So we want to know their medical history and why, right? Well, based on their medical history, certain different diagnoses can put them at higher risk. And this is all respiratory viruses. So we have starts with a D, ends in diabetes. We have our diabetes mellitus patients. Our poor or decreased starts with an I. If you have a immunosuppressant condition, or you're taking immunosuppressant drugs, so your immune system isn't acting at its full capacity, or you're taking drugs that suppress your immune system. For example, in our autoimmune patients, so rheumatology patients, some gastroenterology patients, your IBD patients, they're going to be taking medications that are modulating, they're the immune modulating medications, meaning they lower their hyperimmune response. Well, then that makes them susceptible to communicable diseases. So it's important for us to know that. Okay, also a common thread in our COVID data that we have currently, we have a lot of patients have poorer outcomes with hypertension. Also, our BMI, if it's above a certain number, then that is somewhat predictive of a poorer outcome. And the number that seems to be trending above is above 30. So if you have a BMI, if your patient has a BMI above 30, that would be something that we would want to note. Okay, now, we also want to ask them about, starts with an EX. We want to talk to them about their exposure. Well, why do we want to know about exposure? So we want to understand how many people they've had, close contact, right? Or sick, symptomatic peeps, right? Close contact with sick or symptomatic peeps. Have they been around their family members since their family members started to come down with suspected COVID symptoms or other respiratory viral symptoms? Okay, so these are the symptoms that are also important that warrant an emergency department referral or an ER referral, ED referral. ER and ED are interchangeable terms. ED is the kind of new age way of referring to the ER. So these are the symptoms that would warrant a prompt emergency room referral. Because not everyone with COVID, we don't want them all in the ER. Because a lot of them can self-isolate, plus we don't want to infect other people that are coming to the ER for something else. So we want to keep these folks at home under self-isolation. However, if their symptoms become more severe, we also want to ask them about them, and if we're sending them home, so you might be treating these people, sending them home after you test them, okay, to self-isolate for 14 days. Now, this might be a question you want to ask them. They might, and these are also things, symptoms and warning signs you want to teach them about before you send them back home for self-isolation. You're going to tell your patient, I would like you to come back if you start having these symptoms, you need to come straight back to the ER, okay? So we get concerned about certain symptoms to suspect that might be leading them to a poorer outcome, okay? So if they have chest pain, okay, that's a big symptom. If they have, starts with an S, we already talked about it up here, if they get increased or worsening shortness of breath or dyspnea, something dramatically worse, right? If their cough becomes worse, so increased cough, not necessarily increase in frequency, but a worsening cough. So it might have a drastic change. So maybe they started out with a dry cough, and now they have a productive cough that sounds really junky. So we want to prompt them to come back in for a change in status. okay? Any dramatic change. Also, we talked about that up here, a fever, but if the fever becomes worse, higher, or they had a fever, it went away, or maybe it got a little bit less and then it dramatically worsened. So those are the things we want to have people understand so that they can come back if they get worse. Okay. All right, now we're going to collect before they go home. In the ER, you know, when you're treating these people, you're going to do what is called an NPS collection. And that is known as a nasopharyngeal swab. We've been doing nasopharyngeal swabs since a few years after the H1N1 outbreak. When the H1N1 outbreak first came out in the ER, we were collecting nasal swabs through nasal washes, and they were quite awful for people. So we would, and this is how a lot of times they'll collect an RSV swab on a little baby if they're suctioning the baby as a routine suction, you know, to get the gunk out. Well, they'll just send that swab off for an RSV. And you can also test it for flu. Now, we used to do the nasal wash on adults as well, and it was quite awful. So we'd stick the big giant Deli suction up their nose, squirt a bunch of saline up there, and suck, 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 and then put it on the other side, suction them out, and you can imagine this was quite uncomfortable for people. There's a reason that babies scream when they're getting suctioned and when they're having a wash collection. So now we do, thank goodness, they came out with a nasopharyngeal swab. Now, these are regular swab stick length, same length as our strep swabs that you would collect, same length as you are of swabs that you would collect in a pelvic exam as well for STDs. So kind of a routine swab length. Now, so I'm going to tell you first how to collect it, and then we'll pause the video and I will link us to a YouTube video that I found from the New England Journal of Medicine that shows the correct way to collect a nasopharyngeal swab. So at first when we were collecting them, when they first came out with the test for H1N1 after the washes, we were no longer doing washes and came out with the easier test for adults. So we were just sticking just the swab end. We were sticking the swab end into their nose. Well, we were finding out that that is not accurate. You don't get as many, because what you need is you need as much of a sample in order to test. Just in any statistical analysis and any study, the greater your sample size, the more accurate your test is going to be. So if we stick it further back, what we want is we want to stick it right to the nasopharyngeal junction. And I always joke and I tell patients that I just need to touch their brain, because that's kind of what it feels like. It's about half the length of the swab. Now, everybody's a little bit different anatomically wise, and if you have a deviated septum and you meet resistance, you just go as far as you can until you meet resistance, or half the length of the swab. So we first have them tilt their head back. We insert the swab, right? And you do half the length of the swab or until you meet resistance, okay? Now, everybody's a little bit different, right? So you wouldn't necessarily put it halfway in, but that's just kind of a general rule. If you meet resistance before you put it halfway in, then stop, okay? Then what we want to do is we want to turn, rotate, or twist the swab. So I will look at the clock or my watch the second hand, and we want to do that turning, twisting, and this is the part that, you know, really makes the eyes water and gives them the major want to sneeze tickles, for 10 to 15 seconds. So that's how long you're going to be collecting, because you're trying to get as much secretion on that swab. So now we're increasing our sample size, right? So the more snot and the more goo you collect, better sample size, more accurate sample. Okay, so I see some nurses, you know, just barely putting the tip in because they want to be nice to people. I'm sorry, on this one you kind of have to be Nurse Ratchet, and you have to stick it in as far as you can and then turn and twist. Okay, so droplet precautions. Let's talk about droplet precautions. Respiratory viruses, some of them, because there are viruses that fall under airborne precautions. But let's talk about the ones that fall under droplet precautions, okay? So when we are in a droplet precaution room, before we enter the room, we need to make sure we have the sign up that says droplet precautions. And you need to contact your hospital, infectious disease, or if you work nights, you contact your house soup or your charge nurse, and they should have an isolation cart available to your unit that has everything that you need for each type of isolation. Okay, so what do we wear if we're worried about droplet precautions? Okay, so the first thing we want to grab is starts with an M, ends in ask, mask. So we want a mask, right? Okay, then we want something to protect our eyes, okay? And then we also want a gown, and we want gloves, okay? So mask, eyes, gown, and gloves. Okay, so those are the things that we want in droplet precaution. These things don't have to be sterile because the secretions that are coming out of people's mouths are not sterile. So we don't necessarily need to worry about our gowns being sterile. They're just regular, usually the yellow, kind of opaque, cottony, powdery, weird isolation gowns, okay? So the question can be raised, why aren't we wearing an N95 with COVID patients or these type of patients with droplet precaution respiratory viruses? Well, the reason we don't wear an N95 is because N95 is reserved for airborne precautions. So a droplet precaution, if you wear your regular procedure mask, so this is just our regular procedure mask, those will catch the droplets because the droplets are kind of big. Now when you're N95, if something is airborne, it's going to be a lot smaller particulates, way smaller, and so the mask needs to be a tighter fit and less like smaller pores so that the airborne particles can't get in. So we're not necessarily worried about an N95. That would kind of be overkill, and you want to save those N95 masks for when you have an airborne precaution patient. Now, that being said, if you are at all worried or suspecting and the symptoms warrant an airborne precaution disease, then definitely wear your airborne until otherwise told not to. And as in everything, always follow your hospital protocols, okay? So defer to hospital protocols at all costs or if you ever have questions. Okay, now let's just talk about the infectious disease examples of droplet precaution, okay? So a really funny little, mnemonic. Some people like mnemonics, some people don't. So, you can chuck this if you don't like it, but it kind of helps as far as the whiteboard presentation goes. So, Spider-Man. Okay, so let's talk about Spider-Man. So S stands for, it's a type of fever, and it is caused by the beta hemolytic streptococcus virus, or streptococcus bacteria. So these are infectious diseases that are viruses and or bacteria. So this one happens to be a bacteria. Beta hemolytic strep, wait, what? Yeah, that's what causes strep throat. And when it becomes scarlatina or scarlet fever is when it creates a systemic rash. That's kind of when it makes the crossover from just regular old strep throat to scarlet fever, is when you get that scarlatiniform rash. I'm not going to talk about that because it's not necessarily relevant to this, but this is just kind of a basic thing. Now, does every patient who has strep throat, do we do droplet precaution in the ER? No, but this is just all the different droplet precaution viruses. Okay, now we have our 3 Ps. We have, starts with a pneumonia. I like to say pneumonia. It also falls, so pneumonia could be viral or it could be bacterial, right? So this isn't necessarily listed by the causative agent or the causative, so the causative virus or bacteria could be listed by the syndrome or disease. Pertussis or whooping cough, right? That is a bacteria. And so that one is also under the droplet precaution, transmitted by droplet. And then we have parvo. Oh, wow! So I don't know, in the animal world, parvo is really, really bad. This is a different type of parvo. This is the human kind, and it usually infects little children, and it's called the parvo B19, otherwise known as Phipps disease or slap cheek syndrome. And I'm not going to go crazy into depth about that. That's kind of a pediatric illness, but it also is transmitted via droplet. Okay, next thing that's transmitted via droplet starts with an IN. Every year we got influenza, okay? So all of our influenza viruses are transmitted via droplet, okay? Then now this is a bacteria, starts with a D. It is part of the Tdap immunization. So the tetanus, and then we got pertussis is the P. And then we also have diphtheria. Everybody mispronounces this. So it's actually PH and a TH, so diphtheria. And then we have, I'm not listing the causative agent, so this is a bacteria. I'm not listing the causative agent of this next one, but it infects the epiglottis. And this is a life-threatening emergency. I've seen it once in the ER, not very common, now that we have the Haemophilus influenza vaccine. And so, yeah, it's not as common because that was more likely the causative agent of epiglottitis, but it is one of the things. So epiglottitis, and then we have R, which is rubella, okay? That is the German measles, part of the MMR. So rubella is the German measles, okay? That's different than regular measles, okay? Regular measles is not droplet, okay? But the German measles is rubella. Now you might get this mistaken, or you might confuse this with roseola. Roseola is a little kid virus that usually just starts with a fever, and then you break out in a rash when the fever disappears. So that's different, okay?